Thank you very much, Dr. Ashraf, for the nice introduction. I want to welcome all our friends and our colleagues who are working with us in EFRE and who are attending this webinar also. I want you just to take 30 seconds to pray for all our friends and colleagues who are affected by COVID, and we wish them healing and prosperous life. Just 30 seconds. Just pray for them. Okay. PCOS is a very heterogeneous disorder. It is inherited, it has metabolic, and it has ultrasound sequelae, ovarian sequelae, and it affects the woman in all her life spectrum. Diagnosis of PCOS relies actually on clinical biochemical hyperandrogenism, affection of the ovary either by oligoanovulation or polycystic ovary syndrome. So we all know that there are three main classifications, and you will hear about this from Professor Sharif Ghaffar, NIH, Rotterdam, and the Androgen Excess PCOS Society. So the first question, when was NIH published? When was Rotterdam published? And when was the Androgen Excess PCOS Society recommendations for PCOS diagnosis published? Okay, NIH 1990, Rotterdam 2003, and the Androgen Excess PCOS Society 2006. The three classifications share one common criterion. What is this criterion? Hyperandrogenism, either hirsutism or acne, which is clinical hyperandrogenism, or elevated androgens, total or free androgen. For NIH, both criteria, androgen excess and anovulation, should be present. And for the Androgen Excess PCOS Society classification, both criteria, clinical hyperandrogenism and ovarian dysfunction, should be present. But for the Rotterdam, which is the most commonly accepted classification, two of the three have to be present. Because of the possible variation in the clinical picture, in 2012, NIH proposed an evidence-based methodology workshop which categorized PCOS patients into 4 groups. Phenotype A is hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. Phenotype D is ovulatory dysfunction and polycystic ovary. So what is phenotype B and what is phenotype C? Hyperandrogenism plus for phenotype B and hyperandrogenism plus for phenotype C. So can you think about the answer? Okay. For phenotype B, hyperandrogenism and ovulatory dysfunction, and for phenotype C, hyperandrogenism and polycystic ovary syndrome. So you have to take care that societies dealing with PCOS differentiate between ovulatory dysfunction and the morphology of polycystic ovary by ultrasound. So the current consensus among specialists working in PCOS field is that the Rotterdam criteria is the most appropriate for adult women. The phenotype of PCOS develops in utero because of CNS programming and genetic alteration or epigenetics. And then during adrenarche and adolescence, a lot of factors come into play to affect the clinical picture of PCOS. And in adulthood, you may find hormonal exposure, androgen excess, adrenal factors, or the recent a criterion of different fat storage coming into play to affect the PCOS phenotype. Also, insulin resistance and ovarian factors are important. During folliculogenesis, AMH controls the number of follicles that are 3 to 4 millimeter in size. And androgen increases the growth of small follicles, and it induces atresia in large follicles. And androgen is affected, androgen synthesis is affected in PCOS women. Theca cells is inherently abnormal, and it produces a lot of androgen. So these are the pictures that results in the appearance of the polycystic ovarian morphology, PCOM. So I would like you to think for 1 minute, what is the correct answer or answers among these 6 statements? PCOS is the least common cause of infertility due to anovulation. Is it the least? And to a variant extent, women with PCOS exhibit features of menstrual irregularity, hyperandrogenism, and insulin resistance. Currently, FNPO, follicle number per ovary, more than 12 is considered diagnostic of polycystic ovary, or number more than 20 is considered diagnostic of polycystic ovary. If the ultrasound machine is not accurate, or if there is no possibility of vaginal ultrasound, ovarian volume more than 10 could be used when follicle for diagnosis. Follicle number per cross section, FNAPS, is currently recommended as diagnostic parameter, which is not correct, or which is correct. Okay. So the correct answers are in red. Women with PCOS exhibit feature of menstrual irregularity, hyperandrogenism, and insulin resistance. And currently, follicle number per ovary threshold of 20 is needed for diagnosis. And if this is not possible because of the machine or because of the lack of access to vaginal ultrasound, a vaginal route, a volume more than 10 ml by ultrasound is diagnosed as a criterion for PCOS, PCOM. So, androgen and its receptor, true or false? Hyperandrogenemia, hyperandrogenism is a major feature of PCOS, and there is now substantial evidence pointing toward an important role for androgenic action in the development and progression of PCOS, because it has been thought to be genetic, it has been thought to be insulin resistant, it has been thought to be LH, it has been metabolic, it has been thought to be androgen. So is it now most of the evidence pointing to hyperandrogenemia, true or false? It is true. Hyperandrogenism is a major feature of PCOS, and there is now substantial evidence pointing toward an important role for androgenic actions in the development and progression of PCOS. Clinical and basic research indicates that androgen receptor and estrogen receptor mediated action play a role in the manifestation of the phenotype of PCOS. Androgen action are involved in the generation of and PCOS trait. Which PCOS traits are related to androgen actions, and which PCOS traits are related to estrogen signaling, abnormal estrogen signaling in PCOS? So the answer is androgen actions are involved in generation of both the reproductive and the metabolic PCOS traits, whereas estrogen, abnormal estrogen signaling appears to be most associated with the reproductive PCOS traits. In this diagram, you can see that estrogens, through direct action on estrogen receptor, and androgens have direct action through androgen receptor, or androgen could have an indirect action through aromatization of androgens, or reduction of some androgens to act on the estrogen receptor. So estrogen can act on the estrogen receptor, androgen can act on androgen receptor, or can act on estrogen receptor. So what are the estrogens? What are the androgens? What are the products of aromatization? What are the products of reduction of androgen? What are they? I know that you know all the answers. Okay? So estrogens are estrone and estradiol. Androgen are testosterone and dihydrotestosterone, and those act by the androgen receptor. The indirect action of androgens comes from aromatization of androstenedione to testosterone or estrone to estradiol, whereas reduction of dihydrotestosterone into 3-beta-diol results in a weak estrogen, and those are acting through the estrogen receptor. So androgen can act through androgen receptor or through estrogen receptor after aromatization or after reduction. Okay? So androgen acting by androgen receptor or by estrogen receptor results in what? What does it do? What does it do when it acts through androgen receptor or through estrogen receptor in PCOS? Oh yes, it results in reproductive traits. It results in the PCOS or PCOM morphology, and it results in metabolic disorders. So androgen and the resulting estrogen receptor interaction of androgen produce the picture on the ovary. They produce the irregularity of the cycles or anovulation, and they produce the metabolic traits, as we have said before. And the different extents of activation of androgen and estrogen signaling pathways may give rise to what? What in clinical symptoms that are observed in PCOS? What? These variations in activation of androgen receptor and estrogen receptor result, of course, in variation and heterogeneity in the clinical symptoms that are observed in PCOS. So therefore, recently, the novel pharmacological approaches to manage PCOS should focus on understanding the contribution and importance of both androgen receptor and estrogen receptor-mediated origins in the development of the traits of PCOS, because this is important for treatment. Now, as regards insulin resistance, can you please complete these statements? Number one, what refers to an inadequate cellular response to insulin? What is inadequate cellular response to insulin? None of the Rotterdam diagnostic criteria include insulin resistance is more in women with PCOS than in their counterparts without PCOS. In PCOS, what exacerbates insulin resistance? What is? Insulin resistance and consequent hyperinsulinemia drive ovarian androgen production while reducing what? To exacerbate hyperandrogenism. Insulin-resistant women with PCOS based on which test with this cutoff have the worst metabolic and androgen profiles? I know that you like this type of questions, and you are doing an excellent work on the group of EFRE interest group of PCOS. So the answers are: insulin resistance refers to an inadequate cellular response to insulin. None of Rotterdam diagnostic criteria include insulin resistance. Insulin resistance is more prevalent in women with PCOS than in their counterparts without PCOS. Obesity in PCOS exacerbates insulin resistance, and insulin resistance and consequent hyperinsulinemia derive ovarian androgen while reducing sex hormone binding globin, and this exacerbates the free testosterone. And insulin-resistant women with PCOS based on HOMA test with cutoff 2.6 had the worst metabolic androgen profiles. So the metabolic syndrome is defined by at least 3 of 5 criteria: waist circumference, triglycerides, blood pressure, glucose, and high density lipoprotein. These 5, if you have 3 of them, you have metabolic syndrome. Is this a correct statement or a wrong statement? It is a correct statement. So 3 of these 5 are needed for diagnosing the metabolic syndrome. First case presentation, 14 years, menarche 12 years, BMI 28.5. She's oligomenorrheic, and because we cannot do vaginal ultrasound, the ovarian volume is more than 10 by abdominal ultrasound. She has increased hair growth on the chin, face, and front of the thigh. Should she be investigated? This is the first question. Is she a PCOS case? Is she predisposed to have PCOS? We will listen to a lot from Professor Sherif Ghafar about this, but she is not a PCOS case. She is, and she should not be investigated now. The second case, 21 years, menarche at 12 years, BMI 31, oligomenorrheic, ovarian volume more than 10 because she's virgin, increased hair growth. Her mother is type 2 diabetes. Should she be investigated? Is she a PCOS case? What is the first line of management? Menarche 12 years, and she's now 21. So this is more than 8 years after menarche. So we can now suspect or diagnose PCOS, and she should be investigated. And the first line of management is lifestyle. So the difference between this and the other case is that the other case had menarche, and then she came 2 years after menarche. This is not an adequate period to diagnose PCOS. 28 years, menarche 11 years, primary infertility 3 years, BMI 30, oligomenorrhea, and the number of follicle per ovary 23, and she is hirsute. Should we choose clomiphene citrate or letrozole for induction? This will be answered by Professor Boutros Rizk. Do you think that metformin is useful? Again, this will be answered by Professor Boutros Rizk and by Professor Abdelmajid Ramzi and by Professor Sherif Ghafar. Do you have to do ultrasound monitoring in each cycle during induction? The answer is no. So 30 years, primary infertility, 5 years, male factor, BMI 30, number of follicle 23 per ovary, hirsutism, and she's doing ICSI because she has severe male factor. Would you choose long or antagonist protocol? This will be answered by Professor Boutros Rizk. Would you start FSH by 150 or 225? This will also be answered by Professor Boutros Rizk. Is rect FSH preferable? And this will also be answered, and the answer is no. And what is the type of trigger? Preferably GnRH agonist. And thank you. This was just a brainstorming introduction.